Welcome to another episode of Med Madness, your go-to podcast for all things medical. In today's episode, we're diving into a critical and often misunderstood topic, choriocarcinoma. This aggressive form of gestational trophoblastic neoplasia can have serious implications if not diagnosed and treated promptly. By the end of this episode, you'll have a clear understanding of choriocarcinoma and how it fits into the broader spectrum of gynecological oncology. Choriocarcinoma is a rare but highly malignant tumour that originates from placental trophoblastic tissue. Unlike many other cancers, choriocarcinoma is unique because it secretes the hormone β-hCG, which can be used both for diagnosis and monitoring treatment response. Now let's talk about the risk factors. Choriocarcinoma most commonly arises after a complete hydatidiform mole, a type of molar pregnancy, where abnormal tissue forms instead of a normal embryo. However, it can also develop after a normal pregnancy, a spontaneous abortion, or an ectopic pregnancy. Women with advanced maternal age or a history of a prior complete hydatidiform mole are at a higher risk. Moving on to the clinical presentation, choriocarcinoma typically presents with irregular vaginal bleeding, which may occur months after a pregnancy has ended. Patients may also experience pelvic pain or pressure, and upon examination, an enlarged uterus might be noted. The hallmark of choriocarcinoma is its aggressive nature, often leading to early metastasis, particularly to the lungs. Pulmonary metastasis is the most common, and patients may present with symptoms such as chest pain, hemoptysis, and dyspnea. These symptoms, coupled with abnormal uterine bleeding, should raise a red flag for possible choriocarcinoma, especially in postpartum women. When choriocarcinoma is suspected, a quantitative β-hCG test is essential. Elevated β-hCG levels in the absence of pregnancy are a strong indicator of gestational trophoblastic neoplasia. Imaging studies, such as a chest X-ray, are crucial for staging and assessing the extent of metastatic disease, particularly to the lungs. Interestingly, a chest CT scan isn't typically necessary for staging, as it does not alter the management plan. The good news is that choriocarcinoma is highly sensitive to chemotherapy, which is the mainstay of treatment. With early detection and appropriate therapy, the prognosis is excellent even in cases with metastatic disease. To put this all into context, let me share a real-life case. A 32-year-old woman presented to her gynecologist 6 months after delivering a healthy baby. She had been experiencing irregular vaginal bleeding and shortness of breath. Her initial workup included a β-hCG test, which showed markedly elevated levels despite her recent pregnancy. A chest X-ray revealed multiple lung infiltrates. Based on these findings, she was diagnosed with choriocarcinoma with pulmonary metastasis. She was started on chemotherapy and responded well to treatment, with her β-hCG levels returning to normal within a few months. This case highlights the importance of considering choriocarcinoma in postpartum women presenting with unexplained symptoms and the efficacy of chemotherapy in treating this aggressive cancer. To sum up, choriocarcinoma is a rare but treatable form of gestational trophoblastic neoplasia. Key risk factors include advanced maternal age and a history of complete hydatidiform mole. Clinically, it presents with irregular vaginal bleeding, an enlarged uterus, and symptoms of metastasis, most commonly to the lungs. Diagnosis is confirmed with elevated β-hCG levels, and the treatment is primarily chemotherapy, which offers an excellent prognosis when initiated promptly. Thank you for tuning in to this episode of Med Madness. Don't forget to check out our pre- and post-podcast quizzes to reinforce your understanding of today's topic. And for those looking to deepen their knowledge further, we've also created Anki flashcards covering the key points from today's discussion. Until next time, stay curious and keep learning.